Going to do the foot, ankle, calcaneus, and then tib fib, okay? Next week we'll do the knee and the patella, but you guys can practice all of the above or any of the above next week. So for foot, for all of the ones we're going to do today, we're going to be using the tabletop, so not the bucky, okay? We know that for the tib fib, we're going to maximize our SID, but for everything else, it's 40-inch SID, okay? So I'm going to tell my patient, you can stay sitting or you can lay down, but I need your foot flat on this for me.
Okay.
So for an AP foot, we are going to do a 10-degree cephalad angle, right? Or posterior angle as our book calls it. So 10 degrees. And something that I don't know if I've talked to you guys about yet, I'm gonna move you around on the tabletop so don't be afraid. Whenever you increase, or when you have an angle, for every 5 degrees of angulation, your SID increases by about 1 inch, okay? So before you angle your tube, if you set your SID to about 38, and then you angle to that 10 degrees, it'll put you at the 40, more or less. This becomes more important when we're using large angles, like what we talked about today with inlet pelvis and outlet pelvis. Inlet pelvis is a 40-degree angle, or with our calcaneus, a 40-degree angle. And so you want to really make sure you have your SID set for that, okay? So we'll go ahead and pull this out. And then when we're measuring SID, another thing we haven't really talked about is making sure we're measuring where the central ray is going to be, okay? Because I can measure to my cassette here, and that puts me at 36 inches, but when I come over here to where that is, I'm at 37 inches, okay? So you want to measure to actually where our central ray is at. Up. Come back down with this. Now something else to note is as we move our tube, that can also change as well. So right about there is where I want to be centered. I need to come down just a hair. Wrong one. Okay, so I'm at 40-inch SID right there. I'm centered at the base of the third metatarsal, right? So pretty much just mid-foot. Now something I want you to note, Hannah, if you'll get behind you and get a foot out or that leg. The fifth metatarsal that we can feel on the outside of the foot sits more proximal than the base of the third. So if you look at this foot, the base of the fifth is here, but then my base of the third is here. So it's actually about 1 inch higher than that base of the third, okay? So we can use the base of the fifth to give us an idea, ballpark, where it's gonna be at, but then you still want to go about 1 inch further, okay? So, and that's gonna be 1 inch distal, right? So our fifth sits more proximal, so then we come about 1 inch distal to that in the middle of the foot, okay? Collimation, we're gonna close top to bottom, right about there. Shielding for this, we just use the lap shield. So go ahead and put your lap shield over your patient. Left marker, I'm just gonna throw here. And that is our AP foot, okay? So 10 degrees cephalad angle, centering at the base of the third metatarsal, and then collimate into the size of your foot. Now, you can see here I have light field starting to come off of my image receptor, so I can actually pick James's foot up and scoop my IR back just a little bit. His foot will stay in the same spot, but keep your light field on your IR, okay? So that's AP. So then for my oblique, take my angle off, right? And that's something even like experienced techs will forget to take their angle off. So make sure you take your angle off for your oblique. It's only for the AP. Check here. Now I must have been above 40 earlier, because now I'm at 40. Okay, check your SID, we're at 40. Now we're gonna oblique turn the whole leg inward about 30 to 40 degrees, right? So we wanna turn it until this surface of the foot's about 45 degrees. And then we're centering still at the base of the third metatarsal. Okay, so just like that, have our patient straighten their foot as much as they can, and just like that, okay? So collimation pretty much stays the same. we're just rotating the whole leg 30 to 40 in, okay? Makes sense? So lose the angle, still at the base of the third metatarsal, but rotate the whole leg. And what I mean by that is if he were to keep his knee this way but turn his foot, we're not gonna be properly rotated. We want the whole leg to rotate, all right? And then lastly for lateral, he's gonna bring his leg all the way out, and then we're going to rotate our image receptor, and we're going to dorsiflex the foot. So bring your whole foot this way. There you go. So dorsiflex, now we talked about raising or lowering the knee. So right now he is under rotated because everything's gonna be stacked. We wanna have that fifth metatarsal peeking out a little bit. So drop your knee a little bit more for me. Turn your butt if you need to.
Yeah.
There you go. Sorry. Okay. So we want to be with the length of the image receptor with our body part, okay? So I'm going to tip this to match. And we're centered here on the, I think they say on the medial cuneiform. So hold on, I'm going to lift you up a little bit. There we go. And we're centered in the middle. Left marker, watch your toe shadow on this one so that we don't clip that big toe shadow, okay? So making sure, here the toes look stacked, but you can see that the fifth metatarsal kind of peeks out from underneath, okay? So that's our lateral foot. So no angle, foot all the way on the side, bring the knee up or down if we need to, and then a left marker, okay? So those are your three views for the foot. So AP with a 10-degree angle, base of the third, oblique, base of the third, no angle, lateral all the way out. Make that L with the foot. So we talked about L's with the arm. We're making an L with our foot on the lower extremity, okay? And then centered, it's still basically in line with the base of the third, but we're not calling it that. We're staying on that medial cuneiform, okay? Good? So that's foot. Moving on to the ankle, my patient's going to straighten his leg and put his toes just straight up to the ceiling. Scoot back if you need. Good, I'm gonna scoot that up under you. Okay. So for ankle, and I haven't checked my SID because I know I'm still at 40. I haven't changed it, so still at 40. We're gonna come this direction. Now, when we're doing tabletop stuff, remember, you can move, this doesn't have to be in detent, for one. It can be wherever, in and out. And you can also move your tabletop. So if you just need to make a baby adjustment, sometimes that's easier than moving everything else, okay? Just depends on your comfort level. So, centering for an AP ankle, we find our medial malleoli and our lateral malleoli, those bony bumps, come to the center. You have two tendons that run up the front of the ankle to the foot. You kind of center between those, okay? So I'm gonna come this direction a little bit. And then make sure everything's in a line. I'm going to collimate top to bottom a little bit. So we don't care if we're not seeing all of this shadow because that's not giving us any information, okay? Make sure you're not over dorsiflexed because right now when James is doing that, his toes are gonna end up in his ankle shadow or in his ankle joint. So we want the bottom of the foot, that plantar surface perpendicular with the image receptor, but not over flexed for the ankle, all right? So we're there, we put a left marker. Again, find those two malleoli and come to the center. You have some tendons there that you can center on, and that's the middle, okay? So that is our AP ankle. The oblique for the Mortise is how much angulation? 15 to 20. So we're just going to internally rotate, again, the whole leg. So if James were to just do his foot, is that gonna open my joint? No. So foot straight up, rotate the whole leg inward, 15 to 20. That's gonna be about when that baby toe is straight up and down, okay? It's not on every single person, but that's a good starting place for you. So baby toe straight up and down, that's 15 to 20 degrees. Somehow your leg grew. There we go. And so same centering between the malleoli up on top, and that is our Mortise. So the Mortise opens all of the talar joints. So the tibiotalar, the fibiotalar, and the malleolar talar joint. So between the medial malleolus of the tibia and the talus. Okay, so we're able to see all the way across. Last view for the ankle is a lateral again, so all the way on the outside. Good, you can turn your body if it makes it a little easier. And centering on the medial malleoli now, all right? Perfect. I'm gonna scoop this so that we're just more in the middle of our image receptor. It would have been okay how it was. And I'm indetent. All right, so centered on that medial malleoli, make sure you have light field coming below the calcaneus, and then however far up the tibia is fine. I think the book says get the lower third of the tibia, okay? So, and again, make sure we're making that L because that opens that ankle joint. If we have the foot plantar flexed, so down, then that pushes the calcaneus up and it closes that tibiotalar joint space. So we want that nice L. So ankle, AP, Mortise is 15 degrees rotation, lateral is all the way out, okay? Questions about those? We're good? All right, moving on to the calcaneus. I'm gonna show you guys the lateral first because we're already here, and then we'll do the plantodorsal, all right? Another thing I forgot to tell you guys is you can raise your table up. So you don't have to be leaned over. When you get out into the field, it's best practice to make sure you are raising it up to working height, which is at your waist height, while you're not hurting your back and straining your back. The only time I don't do that is if I have a patient who is maybe intoxicated, something of that nature, and they're flopping around and I'm afraid they're going to fall off the table. We want to keep it low to the ground, okay? Or if a patient is really large and close to the weight limit on our table, we don't want to put the stress on the hydraulics, so leave it as low as you can, okay? Other than that, I always try to bring it up to working height, especially if you're having to wear lead or something, because all that extra weight on you is even worse. So lateral calcaneus, we're centering an inch below the medial malleoli. So find that medial malleoli, and we come about an inch below. I'm just gonna move you this way a little bit. Your whole self. There you go. And we'll move that. Okay. So malleoli, inch below. Now, the way that our calcaneus sits in our body with our foot in this position, it's kind of tilted, okay? So we wanna make sure that we raise the toes and lean it back, so kind of roll your whole leg backward until that calcaneus is flat with the image receptor. So you can put a sponge under here if your patient's having a hard time holding it still. For everyone in here, y'all should be able to hold it for a second, but you roll back until that calcaneus is flat. Does that make sense? And then collimation, we can close like that. We have to have a little home for our markers, so make sure you leave room for that. That's your lateral calcaneus. So an inch below medial malleoli, and then tip the toes up a little bit to get the calcaneus parallel. Good?
So you do your CR first and then roll?
Yeah, I mean, it didn't change it. So if you want to roll first and then do your CR, that's fine, or double check it after the fact, you can do that.
I'm kind of balanced on my hips, so this is kind of an awkward position for the patient.
Yeah, and so, you know, the other thing you can do with that to make it more comfortable is you could bend your leg flat on your back, and then we could like adjust from there too. So the second view for a calcaneus, patient's gonna put his toes straight to the ceiling. This is that plantodorsal axial. So what's our angle? 40 degrees.
Oh, it's just 40?
So we're angling our tube 40 degrees. Oh. All right, give it its little knock so that we make sure that it's balanced where it needs to be. And then this one, if you draw this for practicum, my biggest suggestion to you is going to be get your SID right to your image receptor first, and then put your patient in that central ray, okay? Because right now this is way too much. So we still need to be at 40. Right now I'm at 49, 50-ish. So watch my light field. Right now I'm centered on my image receptor, but as I bring this down to there, that's still 43. I'm gonna come this direction. And now I'm at 44. Where's my? There I'm at 39. Okay, that is 40 right there. Okay. So if you get that set up first, then when you have your patient lay down, you can put them in that light field instead of moving this. Because as you saw, any in or out movement, we're changing our SID. Up or down movement, we're changing our SID because our angle is so steep. Okay, so I'm good there. I am gonna have James, can you scoot back like an inch? Yeah, I was a big inch. Come on this way. Right there. Okay, so we are centering, and I'm gonna move him this direction. So we're centering at the base of the third metatarsal, okay? What that means is basically the top of the fat pad, all right? So if the fat pad is, you know what I'm talking about, like the heel fat pad, center just at the top of that in the middle. That's gonna be the base of your third metatarsal. So straighten your foot out a little bit, and then dorsiflex as much as you can. So with this one, we want the toes to go back as much as possible. And then our collimation, get it nice and tight. So we want to make sure we have light at the bottom of the heel, but we don't need to see the entirety of the foot. Okay? And then I have a left marker there in the bottom corner. That is your plantar-dorsal axial. Okay? Get your SID set first. On practicum, if you're within like 39 to 41 inches, I'm good with that, okay? Because if you have to make any minor change there, it's gonna throw you off. So the thing in the real world is if you're at 50 inches, you're gonna have to increase your technique in order to get a good image. If you're within that ballpark of 38 to 42, like within that 5-inch window, you'll be fine. So that's more the concept with that here, okay? All right, questions? So for calcaneus, plantar-dorsal axial, 40-degree angle, centering at the base of the third third metatarsal, and then lateral all the way on the side, no angle, but then bring the toes up to get the calcaneus parallel. Okay? All right, you can get however's comfortable, James. You do not look comfortable at the moment. So, lastly, we're gonna do our tib fib. Not done with it yet.
I know.
I'm gonna grab a wipe from the early. Hand me a wipe, Paulina. Please. Thank you. Please make sure you're wiping down the image receptors after we put our feet on them. So, wipe it down. Also, there's gloves, obviously. All right, so tib fib, we're using 14 by 17, right? We're going to do corner to corner. For someone, if they're short enough, they will fit lengthwise, but for practicum, learning corner to corner is gonna be the best option. If someone is too tall, you still may have to do an upper and a lower image. So what that means is doing an upper to get as much as you can, and then doing a lower to get the bottom portion that you didn't get on your first image, okay? Make sure you have overlap so the doctor is seeing the entirety of the bone. We'll talk more about that with femur, but with tib fib, most everyone will fit corner to corner. With that being said, we will put me at 40 inches real quick so I can show this. Alright. That's 40. I'm gonna put this way. Now I'm gonna open my light field as much as I can at 40 inches. Okay? And that's not even, let's see, if we go to 17. Do you see how that is not utilizing the entirety of our cassette, right? Even if I open this as much as I can, I'm still not utilizing the entirety of my cassette. So when we drop the table all the way down, which it is, and we bring our tube as high as it'll go, now I'm utilizing the entirety from corner to corner, all right? With that, you have light field on the outside. That's just a give and take. That's something that we're accepting, is there's nothing I can do about the fact that we have light coming off, okay? I talk a lot about making sure your light is on your IR. With this, we can't do that, okay? So we just accept it. So for tib fib, we wanna make sure we're seeing the knee in the proximal and the ankle in the distal. So I'll push this further up. All right, So we know that the malleoli are the bottom of the tibia and the fibula. So if I have my malleoli on the image receptor, then we know we're seeing the distal portion. Approximately, what does my patella articulate with? The femur, yes. So if I am seeing patella on here, we know we have the entirety of our tib fib, right? Because it's sitting at on the femur. So here, my malleoli are there. I have a left marker. I'm gonna come a little more this way. Hello. And then as far as in and out, we just want to be centered pretty much in the midline, so on that shin bone. Okay. And then sometimes you have to do some adjusting, so I don't really like how the corner is up there, so I'm just going to pull this a little bit this way, so I'm having more image receptor there. Bring you this way, and that is my AP tib fib. Okay. So distally making sure I have those malleoli, proximally making sure that I have the knee joint. So as long as I can feel the distal portion of the patella is in the light field, we're good. Okay. Second view is the lateral. So my patient's going to turn all the way onto that left side. Now, in the video that I posted, I showed the patient all the way on their side, bringing this other leg over. That's really important when we're doing lateral knee imaging. With the tib fib, it's not quite as important. If we want to, so if I were to have you do this, I would have you bring this knee up and kind of support that leg. Sorry, snap, crackle, pop. All right, so then with that, and bend just a little bit, bend.
Oh, sorry.
That's okay. So then, right about there. So same thing again, just making sure distally I have those malleoli, and then proximally making sure we have the knee. All right, and maxed out, so I'm gonna move you a little bit. So right there, and I'm gonna turn this to match. And that is my lateral tib fib. So right now with that knee over, we really get those femoral condyles superimposed on one another. If the knee weren't, or if that leg weren't over, we might have a little bit of rotation in the knee, so you see how his knee kind of rolls back. That would still be acceptable for a tib fib because we're not looking at that knee joint itself. But the more pretty we can get our image, the better, right? And we talked about that with humerus and with forearm as well. So that is our lateral tib fib. So AP, toes up, corner to corner, lateral, toes out with the L at the foot, because we still want a pretty ankle joint. And that is our lateral. Questions about those? Someone, you guys.